One of the most important things to do before you start scanning is to ensure correct probe orientation. So what we're going to do in this case is we're going to actually have the probe oriented towards the patient's right as we would in abdominal settings. However, the recording on our actual butterfly machine was in cardiac mode. So what you can do is you can ask the patient to bend their knees so you can have a little more leeway with the abdomen, and then you can push up and from the umbilicus all the way up to the subxiphoid view. Now that you have your probe subxiphoid, you can heel-toe the probe to the patient's right and see the liver, which we will use as an acoustic window to see the heart to the patient's left. So in subxiphoid view, to ensure that you have a clear view of the heart, you need to see the apex as well as the interventricular septum. So this is a sign that we call the lucky number 7 sign, and that you can visualize the apex and the interventricular septum, you can see on the bottom right of the screen, as you are assessing for pericardial effusions. So this view really is for, like I said, assessing the presence of pericardial effusions, and this occurs when excess fluid collects in the pericardial space, often seen anteriorly on first examination, and also to estimate the volume of the fluid as well as assess the hemodynamic impact of the effusion. Now we will move on to the parasternal views. So there are two ways of scanning, but we will use the standard non-cardiologist view while using the abdominal probe settings. So again, check the orientation of your probe, and then place the probe at the third or fourth intercostal space, just lateral to the left sternal border, orienting the probe to the patient's right shoulder. So once you have that all set up, you can place the probe, and an adequate view will be in the plane which includes the mitral valve, aortic valve, cardiac apex, right ventricular outflow tract, and left ventricle, as well as the inflow tract. So essentially what you're looking for in this view is you can look for pericardial effusions posterior to the heart, which will appear as an anechoic stripe in the far field, just adjacent to the left ventricle. But what you really want to be looking at is the anatomy of the heart. One good trick to look for in this view is the rule of thirds, and that you can see how the heart can be split into 3 equal parts in equal diameter. So at the far field, going upwards towards the near field, you can see that there's the inflow tract, which includes the left atrium, the left ventricle, the outflow tract, which includes the left ventricle going out through the aortic valve into the aorta, and finally at the top you can see that there's the right ventricle. This view also permits the measurement of the size of the left atrium as well as interpretation of valvular function. So now we can start with the parasternal short view. And what you can actually do is just rotate the probe from the long view just 90 degrees so that the probe is now pointing towards the patient's left shoulder. Now this view can be obtained at multiple levels along the axis of the heart. We can actually assess the contractility in this view as well as the location of the papillary muscles and chordae tendineae. So you can see the pap muscles there as the 2 little balls that are just protruding outside the left ventricular wall. We can also get a sense of the pressures in the heart, and that we can look for the D sign. So normally the left ventricle should be thick-walled and round like a donut, whereas the right ventricle should be bowed and in the shape of a croissant. When there are increased right heart pressures, you can get a paradoxical bowing of the interventricular septum towards the left ventricle, as you can see in the top left corner, and it will create a certain sign called the D sign, as the left ventricle is now in the shape of a D. We can also get a clear view of the mitral valve, which we know is bicuspid, and will actually look a bit like a fish mouth opening and closing. In the short axis parasternal view, you can also tilt the probe cephalad from your position and try to image the aortic valve in cross-section. This is the so-called Mercedes-Benz sign, where all 3 valves are displayed at the ascending aortic root, which you can see at the bottom right corner of the screen. The next view that we'll try to obtain is the apical 4 view. So the anatomic landmark is the nipple in the men and the left inframammary crease in women, both mid-clavicular. To note, this is the most difficult view to obtain. So in order to obtain the 4-chamber view, you need to have the atria at the far field of the image and the ventricles in the near field of the image. The septum should appear vertically oriented in the center of the screen, and this will separate the screen into 2 halves. The left heart should appear on the right side of the screen and the right heart on the left. Sometimes you can actually put the patient in left lateral decubitus, as this may be also helpful as it brings the heart closer to the chest wall and may help displace the lung tissue. Thank you for joining us for this brief introduction into the advanced cardiac views, and we hope that you learned something. Thanks so much.